Look, it's public hospitals, especially in New South Wales, they're a bit of a funny entity in terms of private billings because private billings are very closely tied in with how staff specialists get paid. So the New South Wales Staff Specialist Award allows you to have part of your salary from right of private practice, so billing patients who elect to be a private patient in the public hospital. It's a very convoluted system, and I don't think we have time to go into the details, but the bottom line is that you're relying on private patient revenue to make up part of your allowed salary. And if you're not claiming all the claims that you should be claiming, or you're claiming incorrectly, then what suffers really is your salary. The problems that I have seen really in public hospitals when we've looked at departments and when we did audits for them is that there are two issues mainly. One is that the people working on the ground, they're a couple of steps removed from the income. So whereas in private practice, when you're a VMO, you see your patients, you bill your patients, you fill out your billing forms, or you put the numbers in digitally, and you get paid into your own bank account. So there's a very clear incentive to do that correctly, because if you don't, the money is not there. When you're working in the public system, especially in New South Wales, because usually it's not individuals, it's groups of people, and all the money that comes in gets divided up between them, and all the RP, the right of private practice payments, come out of one common account. Small mistakes and small omissions, they don't tend to feel like they're going to affect the individual that makes them as much. So people generally don't have that much of an incentive to do it correctly, as much as they should. So that's one part of the equation. The other part of the equation is that because you're not involved in doing the billing in as much as actually generating the invoices and following up the claims, there are omissions and problems there that you have very little oversight of. And then also at the beginning of this chain that leads to the patient coming to the hospital and billing, you don't have any connection really with the admissions, with the patient liaison officers that follow up with the patients, that follow the patient elections. And often the hospital systems that are supposed to be keeping tabs on who are the billable patients, and the hospital systems that's supposed to notify you of the billings that, or the patients that should have billings for their ICU stay, they're not perfect. And often, if at every step of that chain you have a 5%, 10% loss, then that can add up to quite a significant amount at the end. And I have, one example is a big department where we looked at this, where there was close to 25, 30% of billings lost between, all those problems along the way. And where we can help with that is that we can come up with systems to monitor the flow of patients better, to make sure that all the claimable patients are billed, but also to try to cut out the humans in the equation as much as possible. Because when you're using pen and paper to fill out a billing sheet, where you're getting the information from another paper ICU chart or an electronic chart, and you're transcribing things, there are obvious errors that can come with that. And at the other end of that, when you send your forms to the billing department, and when they start transcribing your paper forms back to electronic, then there are errors with that. So we have come up with systems where you can take data out of electronic systems and convert it directly into usable information that can go straight to the billing department, cutting out all the human transcription. And you can pretty much cut down at least the human error to a level of close to zero. So we certainly can help. And it's one of those things I tell people that you don't really know until you know. So a lot of people are unaware of how much money they're potentially missing because they've never looked. They've never looked under the hood. They've never looked at the processes. So I think it's a worthwhile experiment or investment for public hospitals to actually look into this. Because at the end of the day, you may find that you're doing your billing perfectly, and that's fine. But if you're not, then we can potentially offer a solution, and that can save you a lot of money.